Okay, I'm about to go into my patient to carry out the physical assessment. I first of all sanitize my hands and uh, knock the door, maintain patient privacy. Then I introduce myself. Hi, my name is Janet Akirome. I will be your nurse today, the student nurse.
All right.
I'm here to perform lung and thorax assessment. Are you comfortable doing that with me today?
Yeah.
Can you introduce yourself, please?
My name is John Akirome.
John?
Yes.
Okay. Nice to meet you, John. Okay. To perform this exam, I will inspect, palpate, percuse, and auscultate at some point. Okay? So I will be explaining as I'm going. Two ways I will check the anterior side of your lung and thorax and the posterior side. But I would like to start from the posterior side. So can you please turn this way for me? Turn. Okay, I'll move to your back and I will be explaining as I am doing it. Thank you so much. To perform the posterior examinations of the lungs and thorax, I will first of all inspect, and this will be done by carrying out the by observing the shapes, whether there's any contour, the symmetry, whether there's any overlaying skin or any deformities, which I look around and everything looks nice. From there, I will move to palpation. Next is palpation. Mr. John,
Yeah.
when I'm palpating, tell me when it's hot, okay?
Okay.
Palpating to locate any areas of pain, any tenderness, bruises, lesions, or if there's any rib fractures. Everywhere looks normal. Does it hurt?
No.
Okay, thank you. The next thing is to check for the chest expansion. Okay, I will place my thumbs close to the patient's spine at the level of the 10th ribs, and spread my fingers lightly across the lateral thorax. Okay, you will do one thing for me now, okay? You will inhale and exhale deeply. So inhale, exhale. One more time, inhale, exhale. While watching the divergence of my thumb, normally about 2 centimeters, and feel for the range and the symmetry of the movement of the chest expansion. Any decrease in the chest expansion is suggesting the restrictive lung disease. Okay, but everything looks good with him. The chest rise normally, and the inhale and exhale are about 2 centimeter different. Okay, let me move to the next one. The next thing I want to do for you, Mr. John, is to palpate for tactile parameters. I will place my hand at your back and I want you to say 99, 99 over and over again until I ask you to stop, okay?
Okay.
So, say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
I am feeling for the vibrations of the tactile parameters using the ball of my hands to identify areas of increase or decrease or absent parameters. Okay, good. Thank you, Mr. John. Thank you. The next thing I want to do now is a percussion of the posterior thorax. And what do I want to check? The quality and the type of the sound. I will avoid the scapular area because it always gives us a dull sound, and I will move in a ladder pattern from one side to another. And with my non-dominant hand, I will percuss with my dominant finger, striking the DIP joint of my non-dominant fingers and then releasing it. It should be a nice resonant sound because the lung is always filled with the hairs. So let me demonstrate it now. Going right here, this is my non-dominant hand with my non-dominant fingers striking. You can hear the sound. Oh, I promised to go in a ladder pattern. Let me just go back. Okay, good. Okay. Okay, that's good. It sounds good. If there's a when there is a hyper resonant, that may suggest something like COPD. But with my patient John, the sound is good and everything is all right. Also, I want to percuss for the low level of diaphragm descent. Mr. John, can you please breathe for me? Breathe in. I will percuss upward until I see I reach the level of dullness. Okay, good. Well, the last part of it, before we move to the anterior part, is the auscultation. This is sound generated by the breathing. It can be normal or abnormal. The normal includes bronchofascicular, bronchial, or fascicular. The abnormal sound we can have like real, bronchi, wheezing. So I will start from the upper part, but I will avoid the scapula when I'm auscultating. So I use the bell of the to listen. Breathe in for me. Breathe out. Breathe in. Breathe in. Breathe out. 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 Thank you. I can hear bronchofascicular. Everything looks good. So we are moving to the arterial part for to complete our assessment. Thank you, Mr. John. To examine the arterial thorax, I will ask my patient to lie in supine position, and I will observe I will start by observing the skin, the color of the skin, the symmetry, looking whether there is any lesion, any brushes, and at the same time I'm looking at the movement of the chest to see the movement of the respiration. Okay, then the next thing I do is palpation. The next thing I would do is to palpate. Mr. John, if you feel any pain or anywhere that hurts you, let me know. Okay. So I will palpate for tenderness, for in case if there's any mass or lesion. Do you feel anything, any pain? No pain? Okay. Okay, the next thing I will do is the assessment of chest expansion. I will place my tongue along each costal margin with my hands moving along the lateral rib cage. Mr. John, can you please breathe for me? Breathe. Inhale again. Exhale. Inhale one more time. While he's breathing, observing how far the thumbs diverge as the thorax expand, and feel for the extent and the symmetry of the respiratory movement, which is perfectly okay. The chest expand, move along as he's inhaling and he's exhaling. And as I said earlier, that the distance when my thumbs moves up is always like 2 centimeters. I can see that again here. Okay, thank you. Okay, the next thing I want to show is to prepare for tactile remedies. Mr. John, as we did earlier on at the back for the posterior, you will say 99 and you keep saying it until I ask you to stop, okay?
Okay.
So I'm using my Huna part to do that. Say 99.
99, 99, 99.
No, 99, 99, 99, okay?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, thank you. I can feel the vibration and they are both symmetrical. I can feel it right here at the two sides. They are both symmetrical, and that's good. Okay, the next thing I will do now is to percuss the anterior and the lateral chest for donors or resonance sign. So I will avoid the area of the heart because it's always produce a dull sound. So I'm starting from the anterior side using my okay. Okay. Let me go to the right side too. Let me start from here. No, I want to start from the upper so that I will listen to the donors down towards the okay. My fingers are placed in between the intercostal space. Okay. Normal percussion always give resonance sound, but we can look for abnormalities like hyperresonance. As I said earlier, that can be something like COPD or any other abnormalities of the lungs. Lastly, I will percuss for the upper border of the liver from the mid-clavicular line of the first intercostal space. So let me come right there. Okay, I can hear the donors. Okay, everything looks good. The last part of this anterior assessment of the thorax is the auscultation, and this is to assess if there is any abnormalities, abnormalities in the breathing. We have normal and abnormal breath sign. Normal includes bronchofascicular, fascicular, trachea, but at the same time I will still be looking for abnormal signs like crackles, rails, wheezing, and I can get that using the diaphragm of my stethoscope. Mr. John, you will breathe in and breathe out for me, okay? And I will be starting from the above the clavicle. Breathe in for me. Breathe out. Breathe in. 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 Breathe out. Perfect. Uh, the lung field is bronchofascicular, and that is normal. And everything, what I cannot hear any abnormal sound, and that sounds good. So this concludes our assessment for lungs and thorax. Thank you for your patience. Thanks so much.